Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode of The Heart of Hospice is being sponsored by Care Boss, the latest book by Jennifer O'Brien. Care Boss is the book that reminds family caregivers that they are the CEO of their loved one's care. Jennifer has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband. Care Boss is written to empower caregivers, but it's more than just a book. It's a workbook and organizational tool as well. Check it out at jenniferaobrien.com.
Today's guest, Dr. Fred Mirarchi, is working to ensure that every patient has a clear, understandable, and portable advance directive. Ferdinando Mirarchi, or Fred as he is known, is the Chief Executive Officer and Chief Medical Officer of U.S. Acute Care Solutions, Mideo. He's recently been appointed to the chairman position of the National Palliative Care Committee for USACS. He's the principal investigator of the Triad Research Series, which is the realistic interpretation of advance directives. The Triad Research confirms that there's a new nationwide and global patient safety risk related to confusion surrounding living wills, DNR, and post orders. The Triad Research set the foundation for development and utilization of a solution called Mideo, which stands for My Informed Decision on Video. Fred is the author of Understanding Your Living Will, What You Need to Know Before a Medical Emergency, and you can learn more about Mideo at mideohealth.com. Mideo was created to provide a technological advanced care planning tool that's designed to give medical personnel immediate instructions that are from the patient, not just about the patient. And you're going to hear Fred's story and how he learned from personal experience how important advanced care directives are for healthcare providers. He's also going to explain the details of how someone can create their Mideo directive and how emergency personnel can access those records. He and I talked about why Mideo is important for someone with a chronic or a terminal illness. Stay connected for this conversation. It's really valuable. You're going to learn a lot and hear about a fantastic tool in the process. So stick with me. There's a lot to learn. Fred, I'm so glad to have you on the show. Welcome to the Heart of Hospice podcast.
Thank you. Thank you for having me.
We're going to start with an icebreaker question, just so I can get to know you a little bit.
Okay.
So our question is going to have to do with advanced care planning, of course, because that's going to be our topic today. What's one unique thing that's included in your personal advanced care plan?
So the unique thing in my personal advanced care plan is that, I have a Mideo itself, and it actually is something that, I put together, and I was very honest about my thoughts and feelings and has a little note to my wife and family afterwards.
Oh, it's got a personal message in it.
Mm-hmm.
Awesome. Well, we're going to be digging deeply into Mideo and all the different components and how it came about. So I want to hear more about that, and we're going to dig into the details. But let's start at the very beginning. How did you come to work with a focus on advanced directive conversations?
So this is it's a story I told before, and I'm not really quiet about it. So when I was an intern, I basically was taking care of a young lady. She was in her 50s. She was a mom of three, and she was in the ICU, and she was having a heart attack. And as we're waiting to treat her heart attack, she goes into cardiac arrest from VFib. So was an intern. I was a pretty aggressive intern, and I came running, barreling through the ICU, and I'm like ready to shock this lady, right? Because that's what we do. And I got met by a nurse that was holding a yellow or green piece of paper, flashing it in front of me, saying, "Don't shock her, don't shock her. She's a DNR." And I was like, "Whoa!" I got crippled. I was paralyzed. I didn't know what to do. This lady's dying in front of me. This nurse is telling me I can't take care of her. This patient was pretty lucky. There was a cardiologist walking through the ICU at the same time, and he saw what was happening. He basically took me, chucked me aside, took the old-fashioned paddles, gelled them up, shocked her chest. She woke up and talked to us. We then proceeded to treat her heart attack with a clot buster back then, and she went home a few days later. And then if you kind of fast forward in my life and in my training, in my last night of my emergency medicine residency, I was at a level 1 trauma center in Pittsburgh, very highly academic place. And I got, one of my last cases was this 60-year-old gentleman who got brought in by the paramedics, and they had their living will with them. And this gentleman was septic and unresponsive. So I'm like, oh crap, I'm not going to make this mistake twice. So I resuscitated the heck out of him. I put lines in him. I put him on a ventilator. 20 minutes later, his frail wife came in and was like, he didn't want this. He's got end stage cancer. I couldn't take care of him at home. And I'm like, oh crap. So now I got paralyzed again. I'm sitting there. I'm like, whoa, what the hell? I made this mistake on both sides of the coin here, and I realized that this is a broken system and that, it needed some work. So we started doing research. I went into clinical practice. We started doing research, and each time we came through and kind of peeled another layer off the onion and found that, this is a pretty broken process that we're advocating to people as far as advanced directives and the whole patient safety aspect behind it.
Do you think that one of the complicating issues is the fact that there's no standardization across the United States? It differs from state to state.
Yeah. It's not just advanced directives that differ state to state too. It's post orders that differ state to state. It's DNR orders that differ state to state. Some orders are coming into play when you're both pulseless and apneic. Others are just pulseless and not apneic. And then the documents themselves, there's a couple hundred different types of advanced directives on the market today.
Wow.
And when you think about that, and to think that medical teams are going to be savvy enough to know which one applies at any one point in time, it's a broken model, and someone's being sold a bad bill of goods.
Yeah. So while this event is happening, the physician and the care team is expected to go through the advanced directive, see what's there, read the fine print. You can do this, but I don't want this. How confusing. It's like you're saying, I think you use the word cripple. You cripple your healthcare team when you have expectations that they can figure out what you need from that.
Yeah, no, absolutely. I mean, look, if you're in a perfect world, right, in an outpatient setting, you got plenty of time to sit and talk with patients and their family and read through documents and so on. Great. But, in the reality of medicine, emergency medicine, critical care, trauma, hospitalist medicine, like that kind of time doesn't exist, and oftentimes we get glimpses of information, right? We get somebody flashing a piece of paper at us or mentioning something to us. And then we got to then make a clinical decision. That's sometimes a life or death decision, or sometimes an interventional decision, and we got to make a decision to or not to, right? And in that instance, that confusion and that variable interpretation and understanding is very, very dangerous. And it leads to patients being over-resuscitated and kept alive, and it leads to patients being under-resuscitated and being harmed. Either way, it's harm, right? It's a medical error on either side of the equation. but we need to do better because, I mean, we're in a 21st century, right? And we're still kind of depending on, interpretable paper-based documents to really give us guidance on what we should be doing for somebody.
Which is a little ridiculous when you think about the level of technology that we have.
Right? Absolutely.
Right? There's so many different options. So tell me about Mideo and how it can be utilized.
So Mideo is one of the first of the kind types of products and processes that have been developed in this space. People have used video before and kind of did these self-induced selfie videos, but we actually take it to a different level. One, we have an evidence base behind this. We did a Triad 8 study that was a nationwide study involving multiple medical centers, and we showed that injecting video, scripted video specifically, like a prescription for your care, it is so much more accurate to make sure that we provide the initial aspects of care, whether it's life-saving or whether it's palliative. And that in and of itself kind of really separates us. The other thing that really separates us apart is that with Mideo, it's the patient or the healthcare agent speaking, to the medical teams, it's to their families and so on. And it induces this level of confidence of reassurance that they're actually now doing the right thing, rather than, again, that fear and that paralyzing instance where you're not really sure what to do, but then you make an action, And then the really other cool thing that we did with this, and doing this with USACS or US Acute Care Solutions, our parent company, was to figure out a way to build this into a nationwide medical practice so that we can get Medicare to reimburse for it, and that has been very rewarding because we get patients that come through and literally see us and do everything we ask them to do as far as the medical evaluations and the advanced care planning education. We record them in the video and it's covered. And sometimes they have a minor out-of-pocket copay. Other times they have no copay because their plan wants them to do this, and as WAVE co-pays for it.
I think that's a huge deal for a lot of people. A lot of people.
Absolutely. I mean, think about it. What's it cost to go to an attorney? I mean, attorneys tell you often that they don't charge for the advance directive or the healthcare power of attorney document. They just throw it into their estate plan, but there's a charge for it.
Well, but the estate plan is $5,000.
Yeah.
Yeah. So, I mean, let's be real. Let's be honest about what that looks like. I don't know what the percentage is. It would be interesting to know how many people in, say, the age range of 60 to 85 actually go to an elder law attorney and have an estate plan packet put together, because it is cost prohibitive for a lot of people.
It's still a high percentage though. You when you come down to it, the attorneys are the most common way people get their advance directives done. It's the most common way because it's built into their packages, right? It's built into the estate plan, it's built into the elder law plan and so on. So by and large, that's still a big population. But today, look, you can get a 5 wishes document. You can go online and do my directives. You can download forms from the internet. There's so many different ways now to get advanced directive documents, and there's nuances in them all, and the biggest thing again is that we really haven't improved the technology. We've taken paper-based documents and digitized them, right? But we really haven't improved the technology. We're just, made a PDF and pulled it forward in a medical record. What we've done with Mideo today is really improve the process with the technology and enhance the technology so that patients can speak for themselves now at times that they couldn't speak for themselves.
So walk me through the process. If I come to you and I say, look, I want to be a client and I want to record a Mideo video or create a Mideo for myself, what's the next step?
So there's 2 ways that you can get Mideo and so on. There's a do-it-yourself way for the young, healthy population that just need an advance directive as part of their estate plan. And then there's coming through Mideo Health, which is our medical practice that essentially patients become patients in our practice. And then we see them, we evaluate them, we set them up to do a full medical consultation or risk stratification, give them some really disease-specific education as far as their heart disease or COPD, tell them when it's appropriate to do BiPAP, when it's appropriate to go through intubation. Should they give intubation a trial? Should they give defibrillation a trial? Essentially, we really get into the weeds with them so that they really know what they're getting into and what they're consenting to. And then what we do from there after their risk stratification, we actually generate a prescription for their care. And that prescription really then identifies themselves, their date of birth, their photo. This way it all meets all the Joint Commission compliances. It speaks to how they want treated in a cardiac arrest situation, whether it's witnessed, unwitnessed. It appoints the decision maker as well as points to any different documents that they may have. And then in the end, it actually has the buzzwords in place such that if a patient, say, is a full code and wants, aggressive treatment, but should they have a terminal illness or persistent vegetative state, it gives the buzzwords and so on to allow the guidance for the providers to then switch gears and move into a different direction. So, and then on top of what we do, it's a medical practice. So we're not one and done. Every patient that comes into our practice gets risk stratified to see us again. And they see us again, and if they're acute enough and we need to see them again sooner, in 3 months, if they need to see us, and they're healthy and just really did it part of their estate plan, 5 years, but they get risk stratified to come back and see us again. Because the broken process with advanced directives is that it's one and done.
Right.
It's one and done, and then it's in a drawer, and then it's not updated, and it's not kept, and people have no idea what the heck it means. And then, everybody's scouring when something bad happens, and we got to figure out what to do for somebody.
So because our focus is hospice and palliative care here on the show, let's talk about how somebody with a terminal illness or an end-stage illness can leverage Mideo. For one thing, I would ask, do your patients need to be on-site, or do you do telehealth for all of this evaluation and the risk stratification?
We do both. Now, in the home base, as far as where we keep our fulfillment center, we still do in person, and we will eventually get to in person in multiple states. The problem is that obviously it's infrastructure, places, and expenses.
Sure.
So telemedicine was the next easiest way to do this and deploy until we can get sites and centers at different hospital organizations and so on. So. But the good thing about what we do, in that we made it through telemedicine, is that it's now nationwide and it's international too. And we have patients in multiple countries now that got a hold of us and see us, or that are from the U.S. and travel in multiple countries. We have patients right now currently, I believe, in 44 states. And the reason we're not in 50 states is just people haven't found out about us in those other 6 states, So in time, as we continue to grow into the U.S. acute care footprint and so on, we hope to really get into all 50 states fully operational. We want to make this the new best practice. We want to make this the new best practice of advanced care planning, of medicine, of palliative medicine, of resuscitative medicine, whatever the field and facet is, because there's so many different avenues for it. Now, in the world of palliative and hospice, depending where you are, hospice and palliative kind of have a little bit of a turf war. Some hospices are doing palliative medicine now, and some palliative programs are doing hospice, and everybody's trying to grow that market share and so on.
Right.
So, but the one thing that does come about with palliative and hospice is that we seem to forget we got a lot of patients that get over resuscitated, and they get over resuscitated because these documents are very vague. And when we see these patients, we don't always know that they're terminal at that point in time. So at that point in time, we really need better tools that kind of inform us. Does the patient really just want some degree of, customized care for their condition and illness, and progressionary type of care, versus do they really want just end of life and palliative type care and hospice care? And another thing in hospice that gets me a little bit nervous is that we really expanded, right? So hospice, again, has tried to make it so that they see patients upstream more so, and take patients in that are sometimes full code. And the patient, and maybe even the hospice, doesn't know that the level of understanding inside the hospital systems isn't as clear everywhere, and that, that the tag of hospice sometimes makes people think this is an end of life patient, and that, this patient's in hospice, so they're an end of life patient, right? We're not going to touch them.
Automatically a DNR.
Yeah.
Yes.
Yep. So, and you have to be really careful when we try and tell people that, you can go in the hospice as a full code, because everybody else isn't ready for that. Everybody else in medicine is not ready. They have this perception it's a hospice patient. Oh my God, this hospice patient's here. What am I going to do now?
We don't resuscitate hospice patients. It's a waste of time, money, resources, etc.
Yep.
Yeah, which is a terrible thing. Because it robs people who are dealing with end-of-life illnesses of their right to choose the timing and the logistics of how that looks for them. So what I have found in hospice in community-based hospice is we like to cover what I call the big basics when it comes to advanced care planning. We want a DNR. We want a medical power of attorney. If you've got a living will, that's fantastic. But most of the time, we're just looking at the big stuff because it makes it easier for the clinicians.
Mm-hmm.
It makes it clean. If someone becomes unresponsive, heart stops, breathing stops, it's clean. We know exactly what not to do. And if you've got somebody to speak for you, we know who to ask. But I think that's laziness, and that's not for the patient. That is about the hospice agency, quite frankly. Let's be real, because we are bad about that. So I want to ask you, we know that one of the reasons we don't have in-depth advanced care plan discussions is because clinicians, for a myriad of reasons, don't like having them. It's too time-consuming. You dredge up family dynamics. You have to make sure you don't offend anybody's culture or religious beliefs. It's time-consuming. We don't have good places to document, and it's overwhelming emotionally sometimes for us as well as the patient and the family. What do you think are things that we can say to facilitate constructive conversations? I get tired of hearing people say, "Do you want everything done?" I think that needs to be stricken from our practice. Because how does somebody answer that? No, I really just want you to let my person die. They're worthless.
Yeah.
Yeah.
So it comes down to that point, right? Yeah, I think you're mentioning as far as, who's going to own it, right? Who's going to own the conversation? Who's going to plan for it? And I think with the advent of the advanced care planning codes, that you've now given physicians and healthcare systems a way to generate revenue behind it if they do it correctly and so on. So it's gotten to the point now where people will have the conversation because they're documenting the bill for it. It's just, did they do it right? Did they, and it's kind of an arrogant thing to say, I guess, to say if they did that right, because that means it's opinionated and so on. But, there are so many different ways people have conversations that, there really needs to be a structure towards that degree of best practice for a conversation. You mentioned, everybody hearing that statement, you want everything done. So I've seen so many conversations and so many bad conversations. And, when you have conversations, you really need to be sure that you're not thinking for yourself as that provider. You have to think for that patient. Now, I know a lot of payers really don't care to hear that because they really just, kind of are looking at end goals and expenses and did the document really save expenses and so on.
Right.
But when you try and have an advanced care planning conversation, we try and structure it to be very, very non-biasing, middle of the road. There are people that we tend to shift on to try and get them more to align with an end-of-life type of decision because that's what their disease process is and that's what their risk management or risk stratification says for us to do the right thing for them if their wish is not to be kept on machines forever. But we also need to be sure that we're not discouraging certain types of therapies and interventions. I mean, we heavily discourage, CPR, right? We tell people, hey, we're going to break your ribs, we're going to puncture your lung, we're going to tear your esophagus.
Yeah.
Yeah.
And by the way, the success rate is really crappy. So.
Well, think about that for a second. If you're in an unwitnessed situation or some, multiple comorbid state with advanced stage, yeah, you got poor outcomes. You take a look at, anyone in that 40 to 60-year-old age group that has a witnessed cardiac arrest, guess what? CPR works great. It works fantastic in those situations. We bridge with AEDs and defibrillation. We get people in the cath lab and they go home alive with no deficits. So again, we just have to be really careful on how we structure these conversations to make it so that we're not really pushing towards end, because then patients really don't want it. If you really want to just talk to them about end of life, they really don't want it. If you make it somewhere where it's really holistic about them, then they're open to the conversations and feel value in the conversations.
So isn't that really the key? Looking at the patient, their values, putting it in their court and saying, here are the options that align with who you are and what you want.
Yep.
But
absolutely.
Do you think we really take time for that?
Not everybody.
Yeah.
No. Look, there's a paternalistic way to do this, and there's a patient-centered route to do this, right? And I've worked in a lot of health systems that were very paternalistic and that they wanted people to have certain things and not have certain things. And when it got time to an end, they wanted to see like the spending stop and so on. And then the very patient-centered type programs, they're both going to get to the end. They're both going to get to death, right? Whether you're patient-centered or paternalistic, it's just who's going to get there sooner, right? And the paternalistic side feels like they can get there a little bit sooner and save a little bit more money. And the patient-centered route does take a little bit longer because it's more holistic about the patient.
This conversation is so good, but we're going to take a quick break. Hang on for more great content.
This episode is being sponsored by CareBoss, the latest book by Jennifer O'Brien. More than 54 million Americans are serving as unpaid caregivers for family members, friends, or neighbors with serious illnesses. Very few have received the training, guidance, or emotional support they need to succeed in this role. CareBoss, the newest book by healthcare leader Jennifer O'Brien, fills this need by identifying and empowering the family caregiver as the leadership position it is. Jennifer shares her motivation for writing CareBoss.
I wrote CareBoss because I have been a serial family caregiver and I have been a serial CEO in healthcare. And it occurred to me that the family caregiver position is indeed a leadership position. I would go so far as to say it is a leadership position of greater importance than the CEO of a Fortune 500 company, because this is your person.
Jennifer writes with compassion and hard-earned wisdom. Readers will appreciate the empowerment and camaraderie they find in the pages of CareBoss. CareBoss is more than just a book. It's a workbook and organizer that enables family caregivers to lead their loved ones' care sensitively and effectively. You can find CareBoss at your local indie bookstore or on Amazon and at jenniferaobrien.com.
So let's touch back on a younger person. So say I'm a younger person. I don't know where the age cutoff is. I'm pretty sure I'm already out of that particular population. But what if I'm a younger person, healthy, and I want to do the do-it-yourself route with Mideo? What's the process if you want to do the do-it-yourself version?
Do it yourself is easy. You go to the App Store and download our app, the Mideo Card app, or you go to our webpage. You go to Mideo Health and you hit the Get Started button, and it takes you through everything. It'll capture all your demographic information. You can appoint your agent. You can upload any documents you might have. You'll go through a series of video-based education to, kind of simulate what we would do in the office as far as the type of informed, non-biasing conversations we would have, and then you get a script choice. Now, in the do-it-yourself program we lock it down to one script choice, to one, and that it's an aggressive script choice. And that's because our personal feeling is that, and company feeling is, if you're going to decline care and treatment of any sort, any way, right? And it's getting pretty controversial today as far as certain types of treatments. But if you're going to decline it, you really need to speak to someone that actually can give you some real-time information, right? Some ability to make an informed decision about what you're thinking to decline. I get people that come to me and tell me, hey, I don't want to be kept alive on machines forever, right? And I'm like, yeah, right. You just said it, forever. But how about now? You're 50 now. What do you want done now? If you had a heart attack now, would you want us to treat it?
Right.
Right. So, and if you get into those types of programs where you can just do anything you want in those processes, then you get people to take and assign to choices that they're really not understanding. And what they're doing then is actually placing themselves at risk when they come back and enter a broken healthcare system.
So can you change or update your Mideo if your wishes change, your status changes, et cetera? Like your power of attorney changes. Can you change all that?
Yep. Yeah. So, and again, that's another reason why we stratify people to come back, right? Even if you go through a do-it-yourself process, you're getting prompted at the 5-year mark to essentially redo yours, to update those particular things, your health history, your agents, your choices. And in the medical route, in our Mideo Health route, as far as our medical practice, all those people do. And essentially they'll often change because we'll have COPDers that are early on and open to intubation. And then later on, they'll only want BiPAP or a trial of BiPAP, then intubation. And then essentially at times they won't want any intubation at all. They'll just want to have BiPAP. And if they die, they die. So we have lots of abilities to do that. And we have lots of abilities to customize that in video. And the most powerful thing with video is when a provider sees that patient, the inflections in their voice, tone, how they are kind of even at times passionate about what they want to have done versus not want to have done. Again, it instills a level of confidence in those providers and medical teams that they're doing the right thing, where other times we have no idea if we're doing the right thing.
So you can have diagnosis specific directive information, which is a big thing these days. I think we try to predict or preempt, heavy genetic risk of dementia or Alzheimer's or kidney failure or heart disease. And so people will put in these diagnosis-specific or disease-specific directives. Of course, you can't predict every scenario that you might end up with as far as health conditions, but can Mideo accommodate some of that?
Oh, yeah. No, we have lots of stuff that we do today with dementia patients, especially as I mentioned, some of this stuff is getting a little bit on the controversial side, right? Voluntary stoppage of food and drink and so on. And, who's going to honor that? Who's not going to honor that? Who's going to have really, really gut wrenching feelings about that, whether or not to continue it on or not. So with dementia patients, we're actually able to strategize their Mideos so that, we see them at one point in time and we are maybe aggressive. And then at another point in time, we hit different disease specifications and we change it. And that other times when they get to a point that they can't even speak anymore, then we use their agents to actually act on their behalf to read off the information and create the Mideo for them.
So the agent actually creates the Mideo and speaks. Yep. Interesting. What about medical aid in dying, Fred? Can that be incorporated into somebody's Mideo?
Yeah. And we try and walk the middle, right? People have different beliefs and so on. Sure. So yeah, we have patients that have, made a choice for medical aid in dying. So, and here's the funny thing. And again, this is why I talk about people getting sold a bad bill of goods. There's a lot of people that are supportive of medical aid in dying and are like part of these death societies and so on, right? And they put all these documents in place so that they can make sure they die the way they want to, whether it's with medical aid in dying or however. But they're not realizing that they're giving an impression to someone that you don't want treated for things that could easily be treated.
Right.
Right. And that these patients are consenting they would want treatment. They just think that the medical team is going to know what they want. And it's not the case. A lot of those organizations really need to kind of stage what they're putting into completion. Again, I'm not trying to have an opinion to say medical aid in dying is good or bad, but if you're part of the Hemlock Society and you put all this stuff in place, right? When you go to the hospital with your MI and someone sees that documentation, they're not thinking, hey, I'm going to be regressive with you.
Right. It affects how you get treated. It absolutely does. It does.
So, but again, we also want to make sure that people have that right. So we do have people that have Mideos that have statements in there about medical aid in dying. And if they hit a certain point and trigger, that they would be open to the, initiation of the treatment choices that they're putting into their statement. Then it's up to the medical teams, quite frankly, at that point in time. The medical teams at that point in time have to be comfortable and go from there.
Well, and you have clients in 44 states across the United States. Medical aid in dying is not even legal in all those states.
No, but people are figuring it out, right? They're figuring out how to cross state lines and go to
residential requirements. Sure. Yeah. It's absolutely true. So I practice in a state where medical aid in dying is not legal. We don't have any death with dignity laws on the books. But on the podcast, we always try to educate people so that they can make a choice based on what's important to them. And I think it's also really valuable for clinicians to be educated about medical aid in dying and know what's out there. So if they have a patient or a family member who asks, they can at least point them in the right direction.
Yep.
Yeah. You don't have to believe in it or support in it or be against it or any of that. But being educated about it, I think, is crucial. And we owe that to our patients. I truly think that's true. So I wanted to ask you, once I get my Mideo all finished up, I've used the app, so I did it the do-it-yourself, how do I access that? How does if I have an emergency, how do people know that that's in my phone, or how do they get a hold of it?
Great question. So a lot of it comes to our policies and procedures when we see patients and how we educate them and the triggers we teach them to pull out their ID cards, and then our fulfillment team and what they do in the back end. So the first part is how we talk to patients and teach them how to use their ID card. One, we ask people to keep with their insurance cards and driver's license, okay? Because that's what gets pulled out most of the time when you're going into a healthcare system. And I will tell you here, and I say it every time that I'm on some interview or podcast or something, we will find your insurance card. We will find it. It's what we do in hospital systems.
Yeah, because we want to bill.
Yeah. So, and in time, we hope to actually get on the back of the insurance cards and on the back of the driver's licenses. And in certain states, we're actually trying that now. We're trying to really kind of push the needle and move it there.
Oh, nice.
But the other things we do with patients is to make sure that they're aware that anytime you're asked certain questions, how do you want treated in cardiac arrest? Do you have an advanced directive? Those types of questions should trigger the ID card coming out. And again, just keeping it with their insurance and driver's license. Now, part 2 of this is what we do on the back end, the fulfillment team. We have a team that essentially goes through and does a number of different things. One is we get 2 ID cards for the patient, one for them, one for their appointed healthcare agent. They get an in case of emergency magnet for their refrigerator, because just about in every state, we teach medics to look on the sides of refrigerators for advanced directive information. And the copy of the Mideo ID card is there as well. And then we also do some other things as far as fulfillment as well. So for EMS, to further EMS availability to see it and make it transportable. Essentially, if patients are driving, they get a decal for their car, because we know we have end-of-life patients in the community and serious illness patients in the community doing whatever it is, right?
Sure.
And so they get a decal for their rear window of their car, and it basically tells paramedics that they have a copy of their Mideo in their glove box. The other thing that we do is we make sure that everyone gets coordinated in the process. So the referral route that came, so if you came to us by your primary care doctor, a letter goes back to them. The letter goes to your hospital medical records department to be inserted into your electronic medical record in the advanced directive folder. You get a letter to your estate or elder planning attorney, essentially saying what you did, and here's a copy of it as well. And then again, we bring people back in a cycle. So those return visits, we reinforce all of that again as well to make sure that everything is up to date and that we're making it as transportable and findable everywhere we possibly can.
So is there a QR code or something like that that's scannable on the ID card itself?
Yeah, great question. So, when we first came out with this concept of video and so on, everybody thought we were trying to replace documents, orders, post orders, and so on. And we're not. We're really just trying to make it a safer process.
Right.
So the way our ID cards are set up, on your card, you'll have your name, your date of birth, and your photo. Okay. You'll have information based upon a mnemonic we use called code. So your code status, your stance on organ donation, any documents you have, any emergency contacts. And if you have a pulse, the pulse information will be on there as well. Now, on the front of the ID card, you'll actually have a QR code that and I can send you a copy of this if you want. You have a QR code that is to your video, to your Mideo prescription video. And then on the back of the QR code is to any documents you have. So again, we're document agnostic. We don't care. We just want to put the documents in a safer place and make it sure that the Mideo is what gets seen first. And then they can go to the document second, because the Mideo is what's going to clarify your living will or your post order.
Awesome. Awesome. I have a friend who is actually an end-of-life doula, and she was the one who told us about Mideo to begin with, and you and the work that you're doing. And she showed us her Mideo video on her phone. Very interesting. I love the fact that it's portable. You don't have to look for a piece of paper, Yeah, it's because a lot of people are on the move these days. And like you're saying, end-of-life patients, people who are experiencing end-stage terminal illness, they're still able to be out and about. So, Yeah, having it be portable like that is is a huge advantage.
And just think about it. Like, I live in a smaller community, right? 500,000 people or so on. But, if you're in a big city, Philadelphia, New York, Dallas, LA, whatever, where you go to a hospital system isn't your choice often. Those are set by geographic restrictions on EMS. So they're going to take you to the closest place, right? So you may end up in a health system that has no idea who the hell you are.
Yeah, those folks don't know you.
And won't have any documents on you or so on. So you still need something on your person, something, a wearable, discoverable, whatever, portable that can communicate for you and advocate for you. What
about older folks when it comes to doing a Mideo? Because, my my mom's 92, but even 15, 20 years ago, she was tech challenged and she wouldn't have been able to do that. Do you guys have special supports to help older folks manage the technology?
Yeah, we do. And you'll be surprised. Most of our elderly population do very well with it themselves. But we do. We actually built a concierge process into it. So we have advanced care planning concierge that are trained, with our educational processes and so on, and then take the patient through every step of the visit. They take them through, turning on their computer. They take them through connecting to the link to get on telemedicine. They get them through getting to the web portal to make sure that they can actually do their Mideo correctly. They take them through the process, of uploading their documents and ID cards and everything like that. It's a totally white glove type of service. And our patients love it. They really do, because not everybody is tech savvy. Not everybody is open to telemedicine visits, even though it's a very useful thing. But when we use our concierge to do this, essentially it goes very smoothly, and we're able to get from A to Z within 30, 40 minutes and getting it all done for them.
Oh, that's awesome. Streamlined, great turnaround. I love it. Fred, how can my listeners find you, find Mideo, and get started to create their own Mideo?
So simply just go to our website. If you go to our website, mideohealth.com, you'll get a host of information there, as far as either just that you want to investigate the process or get signed up to actually do your own Mideo. I do encourage people to lead by example. It's a broken process out there. And for people who are in this space, if you don't have one yourself, it tends to make people think that they shouldn't get one as well. I'm talking as far as advanced directives and so on. So if you're going to promote it, you really should speak from experience and say, you've done this and this is why you've done it, and this is why we want to do it for you. A lot of what is happening today is really getting to the point that the systems are so broken. There's so many different silos of care. It's hard to have a patient walk through a hospital system and navigate it safely. It's hard for me, and I was in the health system for 25 years as a chair of a department, right?
Yeah.
To get alone, to expect a novice to walk through and be able to navigate it seamlessly is pretty difficult.
I 100% agree, and I'm laughing because I am one of those people without any advanced care planning. I do not have an advanced directive.
Here's your chance.
I know. So it is my hope that by the end of this year, I will have completed my advanced care plan. So I'm afraid I'm creating this community of external accountability where people are going to hold my feet to the fire.
I'm going to be one of them. I'm going to have my team reach out to you. I'm going to have my team reach out to you in a week to get you on the schedule.
Oh my gosh, it's so much peer pressure. But listen, I really think that healthcare clinicians are just as bad or worse. I would like to see if there's ever been a study to find out if people who work with people with serious illness, hospice and palliative care practitioners, if we have a lower rate of getting our own advanced care plans done.
So let me kind of let you know a little dark secret about people in medicine and healthcare, right? They don't trust advanced directives themselves because they've seen how difficult they are. And this is why, this is why technology has to come about and revolutionize what's happening in advanced care planning. Because if a physician isn't going to sign a piece of paper, how can you expect a patient to sign a piece of paper, giving up control of what is going to happen to them?
Yeah. So for all my listeners out there, if you are a hospice worker, you know that your patients need to take care of this and you want to help them do this better. Mideo is a great tool to refer them to, but also for you yourself. Nurses are notorious for do as I say, not as I do, but get your own house in order. Take care of the things because I think it makes a difference. We know the system is broken, but for right now, this is the system within which we are living and dying and being taken care of. So best practice for now is to find these tools that work and work well, and Mideo is absolutely one of them. So Fred, thank you so much. This has been a great conversation. I will watch for the link for my Mideo and get myself started to see if I can actually take care of this. Thank you so much for the conversation.
Oh, thank you. Thank you, and have a good rest of your day.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.